Hi everyone, Dr. Mike here. In this video, we're taking a look at bleeding disorders. Let's not waste any more time, let's jump into it. So to begin, we must do a recap of primary and secondary hemostasis. Otherwise, bleeding disorders just do not make sense. So we're not going to cover it as extensively as the clotting cascade video or primary hemostasis videos I've done, but we're going to do a pretty good job. So we're going to draw it up over here, then we're going to go through our primary bleeding disorders versus our secondary bleeding disorders. All right, so to begin, hemostasis. This is the process, a normal homeostatic mechanism to try and stop us from bleeding out when we damage a blood vessel or get cut. This is something we want to occur. Now, when we undertake the process of hemostasis, we need primary and secondary. So we're going to start with our primary hemostasis. Now, in primary hemostasis, it all has to do with what's happening in the blood vessel or to the blood vessel and platelets. So let's first write that down. It's all about blood vessel integrity and platelets. You have to keep that in mind because it's not just circumstantial that we have primary hemostasis, so stopping bleeding through a primary mechanism, and secondary hemostasis, stopping bleeding through a secondary mechanism, and primary bleeding disorders and secondary bleeding disorders. They're the same categories. So primary bleeding disorders will be issues with the blood vessels and their integrity and the platelets. So let's first talk about, again, what's happening normally. So you've cut yourself and you've damaged your blood vessel. So let's draw up a damaged blood vessel here. Here's the blood vessel and we've got damage. Boom. We don't want to bleed out. So one of the first things that happens is we have what's called a vascular spasm. So the blood vessel constricts due to important chemicals. Some chemicals include endothelin. That gets released by the endothelial cells. And then later on, it includes substances like serotonin and thromboxane. All right, thromboxane A2. But after that vascular spasm occurs, underlying the endothelium, we have collagen, right? That's part of our connective tissue. These are proteins. So we've got all of this collagen here. Now, collagen is negatively charged. We need to write that down, right? So collagen has a negative charge. And that's important because as the platelets fly past, so let's say I have a platelet here, they're also negatively charged. So how do we get a negatively charged platelet to a negative charged collagen? Well, the endothelial cells release something called von Willebrand factor. And von Willebrand factor acts like an anchor. VWF. It acts like an anchor. It holds the platelets with one group of receptors and holds the collagen with another group of receptors, bringing the platelets to the site of damage. Brilliant. This is what we call platelet aggregation. That's happening now, thankfully, because of the von Willebrand factor, bringing the platelets in. Now this activates the platelets. So let's just say over here, we've got activated platelets. An activated platelet becomes spiky and sticky. And that's important because when it's spiky and sticky, it will hold on to something called fibrinogen. So remember, the liver makes an important chemical called, or protein called fibrinogen. And I'm going to draw up fibrinogen like this, right? So let's say that that is fibrinogen. Now, the thing is that fibrinogen, we need to chop off that OGEN to turn it to fibrin, and that's the fibers that create the clot, the mesh network, right? Now, importantly, remember, that's an activated platelet, right? That platelet there is activated, and it's because it's sticky. Now, it will get other activated platelets, and those activated platelets will also bind to that fibrinogen as well. And that's an important process because it's another way of bringing platelets in, activating them, and holding in the very last step of the next stage we need to talk about, which is the clotting cascade. So in primary hemostasis, I've missed out on a couple of things, but these are the important ones to understand here. We need the blood vessel to be damaged, exposing collagen, right? That's important. Von Willebrand factor is really important. Platelets are really important. Activating platelets is important because they hold on to the fibrinogen. And now that I've got fibrinogen here, I'm waiting for the clotting cascade to undergo its whole process to chop it and activate it to form the meshwork, right? To form the fibers. So that's primary hemostasis. Now we need to talk about the one that students freak out about, which is secondary hemostasis, right? So let's talk about secondary hemostasis. Now you might say, Mike, you're Australian. Why are you spelling hemostasis like this? Well, a big chunk of the audience is in the US. Please know that this is not how I usually spell it, right? It's usually H-A-E. Anyway, in secondary hemostasis, we've got all the platelets here. We've got a platelet plug that is formed. We've got the fibrinogen where we want it. We just need to bring the clotting factors in to activate it. So this is also known as the clotting cascade. So you need to know here, it's about, so just like primary hemostasis was about blood vessels and platelets, this is about clotting factors, right? So let's have a look at it. So what happens here? Well, importantly, we've got 12 clotting factors. The liver makes all of them, but factor 8 can also be produced somewhere else. So importantly, we've got what's called an intrinsic pathway, and we've got what's called an extrinsic pathway. I'll talk about that in a sec. The intrinsic pathway will get stimulated anytime there's exposure to negative substances. And that could be collagen, for example, or even a lot of platelets accumulating. Remember I said all of them are negative, right? Okay, let's keep it there and let's now talk more about it. What happens? How do we activate this? Well, we're going to have floating through this bloodstream all of these inactivated clotting factors that the liver's produced. We're going to start with 12. So clotting factor 12 will get activated when it comes across any of these negative substances. So now we've got activated 12. The A stands for activated. 11 is flying past and 11 gets activated by 12. How good's that? Now I've got activated 11. What happens now is 9. I missed 10 on purpose. 9 flies past and gets activated by 11, and now I've got activated 9. Now here's the thing. X marks the spot. I'm going to draw X here, or 10, right? Let's leave this for the moment. Let's talk about extrinsic. Extrinsic gets activated, this pathway gets activated when you have damaged tissue. And the reason why is because it releases something called tissue factor. And exposure of tissue factor to factor 7 will activate factor 7. And factor 7 will activate factor 10. So does 9. So as you can see, the intrinsic pathway, stimulated by negative substances, has a lot of steps before it hits 10. Extrinsic, activated by damaged tissues because it releases tissue factor, only one step. This is faster, but not as good, right? Now, both are activating 10 in order to produce activated 10. But the thing is, they both need something to do it. So 7, like I said, it needs that tissue factor, it needs vitamin K, and it needs calcium. 9 also needs 3 things. What does 9 need to do it? It needs factor, well, what are we missing? We've done 12, 11, 10, 9, something, 7, it's 8, right? So we need factor activated 8. We also need calcium and vitamin K as well. Now we've activated 10. 10 wants to activate the next one, right? So what 10 will do is 10 will activate something called prothrombin. And prothrombin, which is actually inactive factor 2, turns into the active form, which is thrombin, and thrombin is 2A. But in order for 10 to do this, it needs 3 things, just like the others. It needs activated 5, calcium, and vitamin K. Now what thrombin does, we're nearly at the fibrinogen, right? Thrombin will activate fibrinogen. Fibrinogen, and fibrinogen is inactive 1, into its active form, which is fibrin, which is 1A. Look at that, beautiful. So now we've got fibrin, and fibrin are the fibers. They're the threads. We can now start laying those threads down. Now, there's also factor 13. 13 is very important because 13 cross-links them all together, right? Allows them to be held into place. Right, now, I know that this isn't the bleeding disorders, but we need to understand this so we can now talk about the primary secondary bleeding disorders. So, primary bleeding disorders are issues with primary hemostasis. They're going to be problems with blood vessels not being intact, and they're going to be problems with the platelets themselves. Let's first start with the platelets, okay? So if we start with platelets, the issue here is because we're bleeding out, right? The platelets either, let's first write platelets, because you know I can't speak platelets and write at the same time. The issue is either we don't have enough platelets, and we call that thrombocytopenia, right? Or we've got platelet dysfunction. So the platelets aren't working properly. So it's either one of those two things, right? Either we don't have enough platelets, which is called thrombocytopenia, or the platelets aren't working properly. If we first start with thrombocytopenia, right? So what could cause the thrombocytopenia? Well, it could be an decreased production of the thrombocytes, of the platelets. So if we have a decreased production, right, where are platelets produced? In the bone marrow, right? So this is going to be a bone marrow problem, right? And so what type of issues can you have in the bone marrow? So you can have acute leukemia, right? You can have myelodysplastic syndrome, right? You can have aplastic anemia. I won't say anymore. Now, what's the difference between these? Just quickly for your sake. So, aplastic anemia is where the bone marrow just doesn't make any cells. That includes the platelets. Acute leukemia is where the cancer inside the inside the bone marrow is overcrowding the bone marrow tissue. And it basically overcrowds the megakaryocytes, which are the cells that make platelets, just pushes them out so they can't work. And then myelodysplastic syndrome is that there's a problem with the bone marrow where it just makes odd or dysfunctional cells, such as platelets, which means they're not going to be many of them and they don't really work very well, right? So that's a decreased production, right? The issue that could cause thrombocytopenia could also be an increased destruction, right? Maybe we're destroying too many, or let's say increased destruction / consumption, right? So examples of this could be autoimmune disorders. So immune thrombocytopenic purpura. And you go, Mike, you're making words up. I'm not. Immune thrombocytopenic purpura. So immune thrombocytopenic purpura. So immune, it's an immune issue. It can happen after viral exposure. So you get a virus. This happens more so in kids. You get a virus and then you get autoimmune, so antibodies being produced that attack your own platelets. destroys your own platelets, right? Hence thrombocytopenia. What's purpura? Purpura is how it looks, the discoloration. It's like a red blotching that can happen, okay? So that can be the increased destruction. Increased consumption could be something called DIC. So this is disseminated intravascular. I'll just do a line like this. So disseminated intravascular, sorry guys, I know I sound like a child having to pronounce it like this, intravascular coagulation. And you might be going, wait, Mike, this is bleeding disorders. You've just spoken about coagulation. So disseminated intravascular coagulation, it's a strange one. In actual fact, I'm going to do this because it goes across both primary and secondary. What happens here is that disseminated throughout the whole body, right? Intravascular in the blood vessel. And coagulation is actually the first thing that happens. So if you have a blood infection, let's say you have sepsis, or you're exposed to large amounts of tissue factor, right? Tissue factor, because you've got damaged tissue. So you might have rhabdomyolysis, you might have some sort of trauma, right? Something like that. Something has happened to expose you to large amounts of tissue factor. That triggers extrinsic clotting cascade, and you start to form clots throughout your body. Now, the thing with this is when you start to clot, right, you start to recruit heaps of platelets to the site. And if that's happening all throughout the body, you've now just consumed all those platelets, more than you can actually produce. Then if somebody were to cut you, you bleed out. So you coagulate and then paradoxically bleed out. That's DIC. That's disseminated intravascular coagulation. I'm going to talk about it here because it does sit within this category as well. All right, and so we've got decreased production, increased destruction or consumption, and then the final one is sequestration. I should put little asterisks here so you know they're all part of it. So sequestration. All right, so sequestration means we're holding on to it. We're not destroying it really, we're not consuming it, we're just holding on to it. So sequestration happens in the spleen. Now, think about it like this. If you've got, let's draw it up quickly. If you've got the liver, right, and you've got the portal system, so the blood is trying to get to the liver from the GIT, and then let's say you've got this here, and that's going to be blood vessels to the spleen. So there's the spleen, right? So what can happen is if you've got cirrhosis, right? So you've damaged your liver. You've got cirrhosis. It's scarring. The blood can't move through the liver very well, through this portal bloodstream. So the blood backs up, right? The blood backs up. And if the blood backs up, you get something called portal hypertension, right? Just means high blood pressure in the portal system. And that portal hypertension will push blood into what's called the splenic veins. And if that happens, then the spleen fills with blood. And if the spleen fills with blood, what do you think will happen to the spleen? It gets really big, right? And then you get something called splenomegaly, large spleen. The larger the spleen is, the more it's going to start to consume things, and you get hyposplenism. And this large spleen starts to consume, right? Starts to sequestrate, hold on to the platelets. So then you get splenomegaly leads to hypersplenism. Hypersplenism. And that's going to sequester large amounts of platelets, because the spleen actually, normally the spleen holds heaps of platelets anyway. So what this hyperspleen is going to do is more blood's going into it. It gets bigger. It just holds on to more platelets, right? So that's the hypersplenism. So this is the problem with platelets in regards to thrombocytopenia. What about platelet dysfunction? So if we talk, so this is a qualitative issue. So platelet dysfunction, I'm going to have to wipe that off so that we've got more room. So we'll just say sequestration, and then what I might do for you so that you can see that is just say hypersplenism, right? And it just holds on to too many platelets. All right, now we're talking about dysfunction, qualitative issues. So this could be something like Bernard-Soulier syndrome. And what Bernard-Soulier syndrome is it's a problem, right? It's a problem with a receptor. And this receptor is called GP1B. GP1B, glycoprotein 1B. It's a receptor. I'll write receptor so you don't forget it. Where the heck is this receptor? Well, here. Where the platelet binds to von Willebrand factor, that receptor is called GP1B. So right here, we have GP1B. That's the receptor here. That's important. So what that means is if you've got Bernard-Soulier syndrome, that receptor does not work, which means platelets cannot bind to von Willebrand factor. So you do not have no platelet binding to VWF, right? Okay, so that's Bernard-Soulier. You can also actually have von Willebrand factor disease as well. So you can have von Willebrand disease. And there's different types of von Willebrand disease, right? So you've got type 1, hope I don't run out of space, type 2, and type 3. So type 1 is you've got low amounts of von Willebrand factor. Not crazy low, but low enough that you bleed more than you probably should. Type 2 has got normal amounts, but it's dysfunctional. You actually have a dysfunctional von Willebrand factor. And then type 3 is you have crazy low von Willebrand factor. All right? So they're the three types. You've also got another one called Glanzmann thrombasthenia. Glanzmann thrombasthenia. Glanzmann, hey Glanzmann, thrombasthenia. Oh boy. This is another receptor issue, right? So this is a problem with another GP receptor, but it's a GP2B3A. Oh boy. Now you might be thinking, which one is this? So this is why I mentioned these ones specifically. The receptor that allows for the fibrinogen to bind to the platelets, right? That is the GP2B3A receptor, right? It's that one there. That's where it's binding to. So if you've got Glanzmann thrombasthenia, you can't bind to the fibrinogen. That's not good, no clotting. But also the platelets come in and hold on at that site to the fibrinogen. So platelets leave as well. Okay, last thing I want to talk about for the dysfunction is this. It's drugs, right? And the one I want to mention is aspirin. Or you could argue other NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen and so forth. What aspirin does is it stops the synthesis of thromboxane A2. Now, where did we hear that? Hey, thromboxane A2 is a vasoconstrictor vasodilator. Okay, that's cool. So it stops the vasoconstriction. That is going to lead to more bleeding, but it's not the other thing, because thromboxane A2 also helps activate platelets. So I'm going to write thromboxane, let's write TXA2, right? So you know it's thromboxane A2. Also helps activate, right, the platelets. So if you take aspirin, you have less vasoconstriction and less activated platelets, increased likelihood to bleed. Now that's just the platelets, but you said, Michael, what about the blood vessels? And you've left no room. Okay, I'm going to put a little bit of space down here for talking about blood vessels. Let's move that across. So for the blood vessels, effectively anything that makes them more likely to break or damage. So this could be Ehlers-Danlos Ehlers-Danlos syndrome, right? So if we write blood vessel issues, it could be things like Ehlers-Danlos syndrome. That's an issue with collagen, right? You could have a vitamin C deficiency. That's an issue with collagen. You could have too much corticosteroids. That creates an issue with collagen. So if that's a problem, then you have less integrity of the blood vessel. It's more likely to bust open, expose whatever collagen is there, and you increase the likelihood of all this happening. All right, so we've gone through the primary bleeding disorders. Now it's time to go through the secondary bleeding disorders. These are things that are happening here, at the intrinsic, extrinsic pathway and everything below. All right, where do we start? Well, we start by the fact that there's inherited disorders, right? So you can have inherited forms. Now, the inherited forms include the hemophilias. So the hemophilias, so this includes things like hemophilia A, hemophilia B, and also hemophilia C. Now, hemophilia A and B, they're both X-linked, right? So it's on the X chromosome. What does that tell you? If it's X-linked, it tells you that males are predominantly going to present with it and they inherit it from their mothers. So this can be as common as 1 in 5,000 kids or people can get hemophilia A or B. And obviously, it's a bleeding disorder in which hemophilia A is a problem with factor 9. Whoops. Hemophilia A, is it a problem with factor 9? I've got to double check. Factor 8. Hemophilia is a problem with factor 8. I needed to be correct. And hemophilia B is factor 9. Now, let's have a think about this. Where is factor 8? Where is factor 9? So let's use the black, all right? So here's factor 9. Here's factor 8. They're both intrinsic pathway. Both intrinsic pathway. All right, so here's the thing. If you want to test, there's some tests that you can do, right? There's a test that you can do called PTT. This is partial thromboplastin time. Now, partial thromboplastin time, partial thromboplastin time, PTT, this is where you drop in. So you take a patient's plasma, right? Take their blood, get the plasma, and in that plasma, because plasma is where all the clotting proteins are, you drop a negative charged substance. And that negative, and then you count how long it takes for it to clot. Now, if you drop in a negatively charged substance, right? What ends up happening, and it takes a long period of time to clot, it tells you it's an intrinsic pathway issue. And that is measured by, that's partial thromboplastin time. That's the dropping the negative thing in. So what you end up getting is an increased partial thromboplastin time when you have things like hemophilia A and B. Now, hemophilia C is a problem with factor 11. Factor 11, which is also here. So it can be looked at through that partial thromboplastin time, increased partial thromboplastin time. All right, great. What else can we look at here? Well, we need to take a look at von Willebrand disease. And you might think, Mike, you already spoke about von Willebrand. So just quickly, von Willebrand disease, you might go, Mike, that's a primary hemostasis. That's true, but von Willebrand factor holds on to factor 8, right? So von Willebrand factor can hold on to factor 8. And factor 8 is important there. So if you've got von Willebrand disease, you end up having less factor 8. All right, we need to take a look at, so these are all the inherited forms. Let's now take a look at other forms like vitamin K deficiency. So these are not inherited, these are going to be called acquired. Might as well write the heading. These are acquired forms of secondary hemostasis. acquired. So you can have vitamin K deficiency. Vitamin K deficiency. Now the thing is, I told you we need vitamin K, again let's do it in black. We need vitamin K here, we need vitamin K here, we need vitamin K here. So vitamin K is really important for 9, right? 9, 7, 10, and 2. Vitamin K is important for 9, 7, 10, and 2. Those factors. What does it do? Vitamin K carboxylates. It makes them really negative, right? It makes them really negative. Now, if they're really negative, those factors, right, we want to bring it into this site because ultimately, if those factors can come into this site of damage, we can ultimately turn fibrinogen into fibrin. But I said that the collagen and the platelets are negatively charged. So if we make the clotting factors that are flying past negatively charged, they won't stop there. But remember I said they also need calcium. Anytime there's vitamin K, you need calcium, calcium, calcium. So the calcium is sort of like a von Willebrand factor, except it doesn't bind using receptors, which was spoken about, binds using ionic bonds, negative bonds. So the calcium holds on to the really negative clotting factors and then binds down to the negative complex of platelets and collagen. So if you don't have enough vitamin K, you cannot carboxylate. So there's no carboxylation. Now carboxylation is simply adding a carbon with 2 oxygens and the last oxygen is negative, right? So without carboxylation, it doesn't become negative. So how do we become vitamin K deficient? It can be through diet. So you don't get enough in your diet. So this is leafy greens, right? Leafy greens, you know, meat, dairy, yada, yada, but also gut flora. Your gut flora makes vitamin K as well. So if you have an issue with your diet, maybe starvation, but also antibiotics, this could be a problem. Generally, it's a mixture of the two, right? Not enough food and antibiotics can lead to a vitamin K deficiency. So that's one form of acquired. Another form of acquired can be liver disease. Liver disease. Now remember, the liver makes the clotting factors. Liver makes the clotting factors. So if you've got liver disease, your clotting factors are going to be through the floor. And obviously, you can't clot. You're going to bleed out. You're not going to breed. You're going to bleed out. Warfarin therapy. Warfarin therapy. So what warfarin actually does, warfarin actually inhibits vitamin K reductase. So this is the enzyme that activates vitamin K. So warfarin therapy is effectively going to have the same effect as this stuff, right? Vitamin K doesn't work. All right. You can have, in addition to warfarin therapy, you can have heparin therapy. And what heparin does is it increases something called antithrombin. Now, antithrombin does what you think it does. It goes against this thing. Antithrombin stops thrombin, right? And if you stop thrombin, you stop fibrin. You don't clot, right? So that's what heparin therapy can do. And then finally, the last one is that disseminated intravascular coagulation. So let's do this arrow here, and then let's do the arrow here and write DIC, because disseminated intravascular coagulation, the question is, how is it a secondary bleeding disorder? Well, what ends up happening is that when you start to bring in these tissue factors, right, coming from the body, the tissue factors are stimulating a clot to form, and it's consuming the platelets. But what else is it consuming? Remember I said here it's consuming the platelets, but it's also consumes the clotting factors. Consumed clotting factors, right? And if you consume the clotting factors, if you then cut somebody, there's no clotting factors left to be able to clot you up, right? That's that paradox. So, all right, I think we've gone through a lot. This is bleeding disorders, and I'm Dr. Mike. Hi everyone, Dr. Mike here. If you enjoyed this video, please hit like and subscribe. We've got hundreds of others just like this. If you want to contact us, please do so on social media. We are on Instagram, Twitter, and TikTok at Dr. Mike Todorovic, at DrMikeTodorovic. Speak to you soon.